This is an ECG of a 49-year-old man who presents to the emergency department with crushing, severe anterior chest pain for the last 1 hour. Let's look at his ECG. Immediately, we see marked ST elevation in leads V1 to V4, which represents acute anterior infarction. Clearly, this patient requires urgent medical care, but we will go through the stepwise interpretation of his ECG. Looking at the rhythm strips at the bottom of the tracing, we see that there are P waves before each and every QRS complex. The P waves are positive in lead 1 and in AVF, thus originating from the sinus node. The rate is about 85 beats per minute. The P waves have a normal shape in the inferior leads and in lead V1, so there is no left or right atrial enlargement. The PR interval is normal. The QRS axis is positive in lead 1 and positive in lead AVF, so the axis is leftward and inferior, which is normal. Because the QRS complex is narrow and sharp, there is no evidence of any intraventricular conduction delay. There are also no criteria for either left or right ventricular hypertrophy. At this time, there are no abnormal Q waves throughout the tracing, suggesting no evidence of completed infarction. If this patient had presented later, however, Q waves most likely would have been evident. The clear abnormality is the ST elevation in the anterior chest leads, V1 to V4, which is an injury pattern caused by an acute myocardial infarction. Overall, this ECG shows normal sinus rhythm at 85 beats per minute, with evidence of an acute anterior myocardial infarction.